Hello, everyone, and welcome to today's seminar. My name is JJ Rotman, a representative of Orthline, a medical technology company. Today, we partnered with orthopedic surgeon Dr. Robert Burke to hold an educational seminar to discuss the advancements in total knee replacement. Since the seminar is hosted on Facebook Live, all attendees are muted. So if you have any questions during the presentation, please type them into the comment section located below or to the right of the video stream. I'll be notified when this happens, and we'll have plenty of time at the end of the presentation to address everyone's question. So without further delay, Dr. Burke, the controls are yours, and we can begin as soon as you are ready.
Thank you. My name is Dr. Robert Burke. I'm an orthopedic surgeon in Houston, Texas. I'm a member of the Fondon Orthopedic Group and operate exclusively at the Texas Orthopedic Hospital. What I'd like to discuss with you today is new technology that has been out for approximately 5 to 7 years, utilizing smartphone technology to enable the surgeon to have increased efficiency regarding total knee arthroplasty. One of the major goals in total knee arthroplasty is limb alignment. The purpose of limb alignment is to have the implant or the prosthesis in an appropriate orientation regarding the patient's leg in order to maximize function and also to maximize longevity of the prosthesis. With the Neoline system, this allows the surgeon to have real-time guidance during a normal total knee arthroplasty to allow him to proceed with precise cuts to know that these cuts are in an appropriate relationship to the patient's anatomy in order to give the best result possible. Total knee replacement is done for both osteoarthritis, which is a wear and tear issue, and is also as well as inflammatory arthritis. Inflammatory arthritis, the main issue with that is usually rheumatoid arthritis. It's a cell-mediated issue where the patient's body attacks its joints and causes destruction of the joint. Normally, patients with both osteoarthritis and rheumatoid arthritis will experience both pain, both with activity as well as pain at rest, stiffness. Sometimes they will have deformity of their knees, either bowing or knock knee deformity, depending on the disease process, loss of motion, weakness, usually due to the thigh muscles not working as well as just overall disability and not allowing them to function as they would normally. There are various forms of treatment for both inflammatory and osteoarthritis. Initially, things such as anti-inflammatories can be potentially helpful. Injection therapy, either utilizing corticosteroids or what we call hyaluronic acid, which is basically a lubricant that can be put into the joint, can also be efficacious in certain patients. Bracing can sometimes be helpful, along with physiotherapy. When these measures fail and the patient has pain on a regular basis that is greatly interfering with the quality of life, then we're looking at surgical intervention. And the normal surgical intervention for an arthritic knee is a total knee arthroplasty. The purpose of the Neoline system is to allow precise implantation and bone cuts to be made in order to maximize the result of the patient. When we're talking about maximization of the results, we want a knee that is properly aligned, that has excellent range of motion, and that does not hurt. As far as osteoarthritis, there are a tremendous amount of patients throughout the United States and the world that have disabling osteoarthritis. Osteoarthritis is the most common form of disability regarding knee issues, and it accounts for approximately $9 million per year of lost time and work due to that. Osteoarthritis will progress in nature. It can start out as having mild symptomatology as far as pain and stiffness, going into severe pain with pain on a daily basis and the ability to do normal functional activities such as walking, going up and down stairs, and normal things that people do on a regular basis. Joint stiffness is also very common, especially the inability to fully extend or flex or bend the knee. Swelling can occur, especially with inflammatory arthritis. And then the deformities that can occur, either bow-leggedness, which tends to be more common with osteoarthritis, or a knock-knee deformity, which tends to be more common in inflammatory arthritis. Patients will also both feel and hear popping and cracking, and that is a result of the cartilage loss and basically the loss of the non-stick surface of the joint, allowing sort of, if you would think of this as sort of two sandpaper blocks grinding against each other. The main consideration for patients initially with osteoarthritis or inflammatory arthritis are things that we've already discussed: bracing, anti-inflammatories, physical therapy, and then we look at, if those are ineffective, adding things such as intra-articular injections, meaning injections in the knee joint of both steroids or also hyaluronic acid, which is basically a lubricant that can be done that may be helpful in certain patients. As far as surgical concerns are concerned, there are two types of knee replacement: a partial knee replacement or a unicompartmental replacement, or a total knee replacement. A partial knee replacement is indicated for the patient that has isolated disease in only a single area of the knee, usually on the inside of the knee. In order for a patient to be considered for a partial knee replacement, they have to have isolated disease in one compartment of the knee. They have to have no instability. That means their ligaments have to be intact. And they have to have acceptable range of motion, meaning that they cannot have a significant flexion contracture, which means they have to have the ability to extend their knee fully, and they have to have reasonable flexion, usually over 120 degrees. In patients that have advanced disease, meaning arthritis in all three compartments, involving both the kneecap, the inside and outside of the knee, with associated deformity, then total knee arthroplasty is the appropriate procedure for them. The major degree of success with any arthroplasty, whether it's a total knee arthroplasty or a partial knee arthroplasty, is limb alignment. What we want to achieve after either partial knee arthroplasty or total knee arthroplasty is to have the limb aligned properly. That means if we were to draw a line from the center of the patient's femoral head or hip joint, it should pass through the center of the knee and through the center of the ankle. And that allows us to have a properly aligned joint. And a properly aligned joint will function as it should. It will wear normally, so there's not excess wear due to malalignment. And it will also allow greater function as far as range of motion is concerned. The purpose of the Neoline system is to allow the patient, the surgeon, during real-time surgery, to assess the alignment of the joint to make sure that when the bone cuts are performed, that they're allowing the surgeon to restore proper limb alignment. The Neoline system is a GPS-guided system. It has an internal gyroscope with direct readings off the system, which allows the surgeon in real time to determine the alignment of the limb and the accuracy of the bone cuts that are being made. One of the major advantages of the Neoline system is there's no significant time taken to register the patient's knee prior to surgery, which means that we're not adding excessive time to the patient's surgery while they're asleep, as with other systems that can have a significant amount of time before any type of surgery is done, just in registering the patient's knee prior to starting the operation itself. The other advantage of the Neoline system, which is crucial, it does not add to the patient's surgical time, and that is key. The longer the surgery takes, the more potential for infection, the more potential for blood loss. So shorter surgeries that are done well tend to have significantly less potential complications than longer surgical time. The Neoline system, again, allows precise orientation of the patient's bone cuts, so we're restoring the normal anatomy by putting in simple guides that allow us in real time to determine the accuracy of the bone cuts. And I cannot stress more the fact that when you have a system that is easy to use, that is reproducible, that does not add to your surgical time, that does not change your technique as far as the ability to do either a partial or total knee arthroplasty, then that has a significant amount of overall improvement in both patient satisfaction and surgical success. I have been using the Ortholine system for the past 4 years and have done over 1,000 total knees and total hips with it. And I have been extremely satisfied with results, as have my patients. And right now, I'd like to thank you for your time, and I'll be happy to open this up for questions.
Great. Thanks very much for the information, Dr. Burke. So we have had a couple of questions come through in the chat. And I do want to remind anyone that if you do have questions, please be sure to enter them in the chat box to the right or below the video stream. So the first question we have here is from someone who has never been diagnosed, but has had injections before in both their knees. And she thinks she would be a good candidate. She's had PT and braces, and she wants something that might last a little bit longer. Is there anything she can do other than surgery that you might recommend?
The first thing I would recommend is the patient to understand exactly what her diagnosis is. Does she have bone-on-bone arthritis? Does she have inflammatory arthritis? Does she have a meniscal tear? So that would be the first thing that I would recommend, is determine exactly what her diagnosis is. If she does have severe osteoarthritis and does not wish to have anything done surgically, there are potential biologic agents that can sometimes be helpful, such as PRP, which is platelet-rich plasma, and there are stem cell preparations that can also be done as a potential non-surgical treatment for the appropriate patient. But the first thing I would strongly recommend is the patient understand what their diagnosis is, because that is paramount into understanding the best way to treat that.
Very good. Thank you. Another question from someone who has complex regional pain syndrome. They've been told that they cannot have a knee replacement. Is that true?
Well, the question is do they have an anatomic issue along with the complex regional pain syndrome? Certainly patients that have complex regional pain syndrome will tend to have more issues with postoperative pain than in someone that does not have that problem. But if they do have a structural problem where they have significant articular cartilage loss, they have bone-on-bone disease with deformity and loss of motion, then those patients can be improved with joint replacement. However, given the understanding that pain management will probably be more difficult with them than in someone who does not have that problem pre-existing.
Does Medicare cover all the cost for a knee replacement?
Medicare will cover 80% of the cost of total joint replacement, and normally the patient's secondary will cover the other 20%.
What is the average surgical time for a total knee replacement?
In my hands, the average surgical time is less than 25 minutes.
Can you talk a little bit about the post-operative physical therapy?
Absolutely. Our patients are brought in the morning of surgery. They are up and walking in the hallway the day of surgery, and they are discharged the following day. They start outpatient physiotherapy the week of surgery, and I normally recommend going to physiotherapy with a supervised physical therapist twice a week for the first 4 weeks after surgery. In addition to that, I highly encourage patients to do things such as a stationary bike. They can be in a swimming pool 3 weeks after surgery. Walking either outside or using a treadmill or an elliptical walker is highly encouraged. And most patients within 2 to 3 weeks are fully independent.
Great. That might conclude the questions that we have. Oh, nope, there are a few more that are coming through. Medicaid, can you talk about Medicaid? Is that something that you cover or take?
Yes, that is correct. We do accept Medicaid patients.
Do you recommend doing both knees at the same time?
In my practice, I tend to discourage that. I find that simultaneous bilateral total knee arthroplasties tends to have a higher degree of morbidity, especially with potential blood loss, as well as the increased risk of blood clots. So what I recommend to my patients that have bilateral disease is to do their initial knee replacement, whichever knee they feel is the most symptomatic, and then 3 to 4 weeks later, follow up with the opposite knee. And in my hands, my patients do much better with that as opposed to having both knees done at once.
Great. Do you typically move from steroid injections and then to, probably mispronouncing this, hyaluronic acid and then replacement?
It depends on the patient. If a patient has come in and they have had a series of injections in the past, which have been ineffective, and they have severe arthritis, I don't recommend repeating those. If a patient comes in that has never had any treatment at all, then the initial treatment would be to consider a corticosteroid injection. And the reason I do that is that most insurances, to cover the cost of hyaluronic acid, would require at least 1 corticosteroid injection. So in patients with no treatment at all, we initially begin often with a corticosteroid injection, followed with anti-inflammatories if there are no contraindications with the patient. And if the patients have pain refractory to that, then we consider hyaluronic acid injection to follow.
Great. So you mentioned PRP and stem cells earlier. Is that available through you? And is there an age cutoff to that treatment option?
There's no age cutoff to stem cell therapy. There is consideration of the patient's disease severity. In patients with severe osteoarthritis, severe deformity, those patients really do extremely poorly with biologic treatment. Patients that have less severe deformity and have moderate osteoarthritis tend to do much better with biologic treatment. In my practice, PRP or platelet-rich plasma, they use fairly solely for inflammatory conditions of soft tissue, such as rotator cuff tendonitis, patellar tendonitis, Achilles tendonitis, tennis elbow, that type of thing.
After a total knee replacement, how long will it be until you can drive again?
If you're having a left total knee arthroplasty, you can be driving within 7 to 10 days. Regardless of where you're driving, with a right total knee arthroplasty, I allow my patients to drive locally for short distances after the first week, but I tell them to avoid things like a freeway or interstate for the first 14 to 17 days after surgery, just because of the reaction time it would take to get off the brake and onto the accelerator.
If you have a torn meniscus, is that repairable?
It depends on the age of the patient. It depends on the location of the tear. If the tear is in an area of the meniscus where the meniscus attaches to the capsule, where there's vascularity, then those tears can often be repaired. What we do see, however, is after age 35, there is a significant drop-off with the rate of meniscal healing. So normally, when I'm doing a meniscal repair, I tend not to recommend that in patients over the age of 35 due to the high failure rate of meniscal repair.
How long does the typical hyaluronic acid injection last? And is it a one-time injection?
Well, there are various forms of hyaluronic acid. Some can be done as a single injection. Some can be done once a week for 3 weeks. So it just depends on the brand, if you would, which your insurance company will allow. What I look for in my practice for me to determine if this is a success is a minimum of 9 months of good pain relief. If I'm able to achieve that in a patient with hyaluronic acid, then I consider that a success. If a patient cannot get close to 9 months of pain relief after a hyaluronic acid injection, then I do not recommend repeating that.
Can you talk about partial knee replacements a little bit?
Absolutely. Partial knee replacements, again, are done in patients that have isolated disease usually on the inside of the knee. They don't have significant deformity, either bow-leggedness or knock knee. They have a stable knee, which means they have no ligament issues, and they don't have significant disease underneath their kneecap. The time of partial knee replacement, as far as timing of surgery, is relatively the same as a total knee arthroplasty, and the rehab and recovery are essentially the same.
Wonderful. And it looks like that might have been our last question here. I'll just give everyone a couple of minutes or a minute here in case there's a last few questions to come through. In the chat, I'm going to enter in Dr. Burke's contact information if you'd like to make an appointment with him. You can do that through phone, email, or through his website right here. So with that being said, I would like to thank everyone for attending our seminar, and I hope they found it helpful and informative in their healthcare related decisions. So thank you everyone for attending. And Dr. Burke, thank you very much for presenting today and attending or being here as well.
Again, I'd like to thank you all for